Hello, everyone. In this video, we're going to talk about public health and kind of a wrap up. I thought this is a good place to kind of end our content for the class because we've talked about public health lessons throughout, but maybe now that we've done so, it'll be a little easier for you to understand if we dig into the technical details here. So I always have kind of a public healthy emphasis throughout my slides, but let's give it its due diligence at this point. So in this lecture, we're going to cover what is public health. We're going to talk about epidemiology, which is an adjacent field that informs a lot of public health action. And we're also going to dig into some theories that can help us make better sense of what we're seeing and what we can expect from public health, including the crisis and emergency risk communication model, which is one that the CDC uses, exemplification theory, and negative dominance. Those are going to give us a little bit they're pretty straightforward, but they're just giving us something to expect from messaging. And we're also going to revisit the dilemma of public health and the lessons for public health accordingly, going all the way back to lecture 1 on this. Let's see what we've got to work with. Let's begin with the definition from the textbook. This is the definition of public health that Dupre and Overton give us. The process of preventing disease, prolonging life, and promoting health through organized community efforts to maintain healthy environments, control infections, provide health education and health services, and develop social mechanisms to ensure that every individual has a healthy standard of living. That's a big definition, and there's a lot of important points in there. This definition has changed a little bit across the different textbooks, which makes sense because we had a pandemic in there at some point. I can't tell if Dupre and Overton are as dissatisfied as I am with the pandemic response, or if they're trying to be more politically correct, but at least that means they're mostly sticking to the facts here. So what we have here is the process of preventing disease, prolonging life, and promoting health. Let's start with that part. We're trying to do at least those 3 things: prevent, prolong, and promote. So we've got some great stuff to work with. The other things in here are the mechanisms by which we would do that: organize community efforts to maintain healthy environments, control infections, and provide health education, health services, and develop social mechanisms. That's an interesting part, social mechanisms. So what does that look like? Well, maybe our theories will start to give us a good sense of that. But as you may recall from the pandemic years, the biggest issues were arguably social mechanisms, right? The politics of it, how no one wanted to be wrong, but everyone wanted to show how much they cared about each other, or maybe they didn't. Those social dynamics must be considered, and that's part of what we're doing here as health communicators. But let's dig into this a little deeper, and maybe we'll see what we can figure out. When we're talking about public health, we really are talking about large scale, rubber meets the road. This is health communication. We want to see how we can make it work in practice. This is what practicing what we preach, ideally. Um, One of the ways in which we improve our understanding and gather knowledge about health information is the field of epidemiology. You may have heard this word before. Let's talk about what that means. The definition on the left here is one that's coming from an epidemiology and biostatistics textbook. I think I've got it here on my desk. Ta-da, right? This one is from 2001. This came from my dad's bookshelf, but I think it's interesting to compare some of these definitions across time. Back in 2001, they were defining it in a number of different ways. They're saying epidemiology can be thought of as one of the ways in which disease, injury, and clinical practice are studied. So we can compare that to our public health definition. This is more about the study of, thus the ology, of disease, injury, and clinical practice. But notice that those are already spanning multiple levels too, right? Disease is not just happening at the individual level, but that's part of what we're talking about here. The scientific study of disease can be approached at 4 levels, the definition goes on. 1, the submolecular or molecular level. For example, cell biology, genetics, biochemistry, and immunology. Number 2 here is the tissue or organ level, so going up from cells to organs. 3, the level of individual patients, so from the organs to the individual. And then 4, the level of populations, specifically epidemiology here. So they seem to be talking about epidemiology mostly as the population level manifestation of disease and illness. We can compare this to the CDC's definition as of 2012. Not sure why we couldn't find a more recent definition than that, but maybe this one just works for them. The study and distribution of determinants of health-related states or events in specified populations, and the application of this study to the control of health problems. We can see some parallel between the CDC definition here and this the epidemiology statistics biostatistics textbook definition here, and that we're when we're talking about epidemiology, we're particularly interested in these kind of dynamics of disease, spread, transmission, development, pathology, all that kind of stuff. So ideally, epidemiology is studying disease to prevent and control health problems. That's pretty good for us to work with. That meshes well with public health. When I talk about definitions of epidemiology, I like to use this article. This is a very old article, 1996. That's almost 30 years old now. But this is a good article. If you take later health classes with me, you're probably going to end up reading this. I like this article because it's drawing attention to a deleterious trend in public health and epidemiology. Um, while it is almost 30 years old, this is still an issue today. So it's worth talking about. What Pierce was talking about back in 96 was that you had this kind of disconnect between traditional epidemiology and modern epidemiology. Essentially, those first three numbers on that list in the epidemiology definition, they're talking about some pretty small level stuff. And so what Pierce was arguing in 96 is like, that's great, dig into that small stuff, figure out what is causing these problems. But he was also kind of arguing that there's diminishing returns in a way. The more you focus on those microscopic little things, the more you neglect the individual. And if you're neglecting the individual, you might also be neglecting larger population level trends. This was way before COVID-19 that he was making these kind of commentaries, but one of his concerns was that the push is away from the bigger trends and more onto individual focus. So as we shift that whole thing up and we're saying, all right, well, what can we do about these diseases? Then we have the focus back down on the individual. So back then, he was saying that that reductionist approach is pulling away from traditional epidemiology, which is looking at the population level stuff. And when we do that, we might make the mistake of saying, well, you as an individual are increasing your risk by doing this thing or not doing this thing. And that ignores other important things such as environmental justice, sociocultural determinants of health. All that kind of stuff factors into our health and health trends in society. So in 96, Pierce was concerned that we were driving away from that like big picture perspective, and it ended up kind of victim blaming people. So when they were affected by a disease, like, well, it's kind of your fault in its own way because here's the individual stuff. So that's something we want to balance here as well, because I think that we saw some of that in COVID-19 as well. It's like, well, you see these population level trends, and some of the arguments were simultaneously saying, do this for the common good, but it's your fault that this is you people are bad, do the thing, right? So it's kind of a contradiction in that way. So this tension has not been removed from epidemiology. We'll be able to make more sense of that as we talk about some theoretical stuff here in a moment, but keep that in mind for now. So again, to summarize what Pierce was arguing about or was concerned about back in 1996 is saying that this reductionist approach focuses on the individual, blames the victim, and produces interventions that can be harmful. That would be bad. This is a shift from the macro perspective to the micro perspective, as I mentioned previously, which could interfere from the central goal of disease prevention. Because if we're too concerned with what each individual should be doing and trying to micromanage people's behavior, then we might lose track of what's actually happening at the larger level. We could also connect this to the ecological fallacy, which I've mentioned before, in terms of saying, well, just because we can detect a population level trend, and we could mathematically then take that trend and say, all right, divide that by the population. Oh, you have this much risk. Well, that's not the case all the time. We have things like stratified risk. That would be an ecological fallacy. To look at, say, the infection rates or mortality rates of COVID-19 without considering things like age, sociodemographics, comorbidities, anything like that, that would be causing a problem if you then say, all right, well, there's this much risk. Let's divide that evenly between everyone else and say, you young, healthy people, you're going to die if you get COVID-19. And worse, you're going to kill grandma if you don't get the vaccine. That's not productive. It's not good public health. So the ecological fallacy means inferences about individuals drawn from the population level. We would want to avoid that when we're doing something like epidemiology. We need to kind of keep our perspective on that population level, even though the recommendations are going to be for individuals. That is a difficult balance to be reached and maintained. Pierce saw that in 96, and we're still dealing with that today. If this was and is true, it's bad news. Let's transition to some of our theories, and we might be able to make some more sense of this and start thinking about how one could maintain that balance. The CERC model, this is what the CDC uses to talk about uh, health crises. So they break this into 5 stages. Pre-crisis. This is your capacity building, your strategies, your assigning of roles. Think of the crisis communication plan and the health organizations lecture. That's what we're talking about here, except we're doing this for a whole nation, presumably, or a municipality, anything from local municipality up to the nation, I would say. Then you have the initial event. Then you've got your outbreak. You've got the crisis on your hands. Your goal at this point is to inform and reassure the public. They need good information and they need reassurance to reduce the uncertainty and promote self-efficacy. It's not just token reassurance. The goal here is to provide them with the information they need and promote their own self-efficacy. So we need to be careful in a crisis situation how we communicate about this stuff. We don't want people to feel like they have no control over the situation. They don't want to feel like the authorities have no control over the situation. But we do need people to give people productive things to do. Then you have maintenance. So this is explaining the ongoing response and recovery plans that are happening to correct misinformation that may have emerged along the way. That can be very tricky when you don't have enough information, and it's kind of a moving target, as we've heard that phrase a lot in the past 5 years uh, and beyond. Resolution. After you've corrected the thing, you're still going to describe ongoing efforts to keep the downward trajectory of the infection or whatever it may be. And you should also be at this stage encouraging discussion about what went well and what did not go so well. Evaluation here, this is post-response. We say, well, what went well, what didn't go so well, how could we improve this? If we were doing this face-to-face, I would encourage you to think about what stage you think we are for the COVID-19 response. Are we in the resolution? Are we in the evaluation stage? And then I would follow up with that question and ask you, do you think the authorities dealt with this stuff appropriately? Did the CDC deal with this appropriately? Did the CDC, as the pandemic was waning down, did they encourage discussion? You probably guess what my answer to that question is. Did they identify problems and mishaps? Was this happening transparently? Is it realistic to expect them to do that? Well, that's a question for our considerations of the public health dilemma and here in a moment. But let's continue looking at some more theories that might help us make sense of this. Now, these 2 theories I pulled from the textbook to talk about because I think they mesh well with things that we've previously discussed, and I think they might be useful to you in that way. One is exemplification. This is simply saying that people respond to clear examples. So when we're talking about messaging, it's good to have exemplars. It's good to personify. If you remember back to public speaking, personification, giving an example of a trend or a thing. Well, this is exemplification theory in practice. We can also compare this to social learning by Bandura in 1977. Remember that from our health and media lecture where we're saying that people learn by watching and attending to depictions of consequences. So we don't have to just learn from our own actions. We can learn from other people's actions as well. We also have the negative dominance kind of model coming up here in this textbook. This is just another fancy way of saying that people are risk averse. They tend to focus on negative information, particularly when they're stressed out. So what's the lesson there for us as health communicators? The textbook recommends outweigh the bad with good. 2 messages to 1 is what they say. It may take more than that in order to get the right messages through. So I don't think any of these theories are particularly new in relation to other stuff that we've read, but it's worth reiterating in the context of health communication and public health. Let's revisit our idea here with public health. So this is the exercise I asked you to consider all the way at the beginning of the semester, and I've done that for several years. I'll probably continue to do that for several years until everyone's bored of me talking about it, if you're not already. But it's still relevant, so we still talk about it. Recently, Anthony Fauci, as of the recording of this video, the beginning of this year with the transition from the Biden administration back to the Trump administration, or into the new Trump administration, we saw President Biden on his way out, among other things, pardon Anthony Fauci for Not sure. But it's still relevant, and we should probably continue to ask this question. When, if ever, is it okay to lie about health and health choices? You may recall from that exercise, we were reading a dated Slate article that was talking about the ongoing pandemic response and things that Anthony Fauci had said that were deliberately misleading, arguably well-intentioned, but they don't work out so well in the practice, and we know now probably why. The dilemma of public health is that this is communication at work. Whether or not public health people have taken health communication classes, this is what our kind of field of study is learned to deal with, is designed to help people deal with. For example, you look at this diagram. This is also coming from this epidemiology textbook over here. This is simply illustrating what herd immunity is. I put this back up on here because you may recall one of the quote noble lies that Anthony Fauci was telling was that, wow, we need like 80% herd immunity for this to work. Well, this is a diagram that's simply showing how herd immunity works. One, in absence of herd immunity on the left there, you see that transmission's basically unchecked. People just spread the illness. The presence of 50% herd immunity, that means if half the population has herd immunity, within 3 disease generations, most people are not getting sick anymore, right? So that's how herd immunity works. This is coming from a, an epidemiology textbook. Do we really need to talk about this here? I don't know. I just like to show this example. Like this is health communication. Explaining how that works to people is a little bit different than saying if we don't get 80% herd immunity, everyone's screwed, right? That kind of thing. It's not realistic. It doesn't reflect the science. And it's another negative message that's not really helping people. So if you're just pounding on all these negative messages and maybe like one positive, like, all right, go get vaccinated, that's not good enough. And that is a lesson that's been established in public health and epidemiology for many, many years. When that fact is overlooked, problems arise, ethical and practical problems. Human problems scale up. So we want, when we're thinking about epidemiology and public health, we do want to recognize that individual behaviors influence population level trends, um, but that just means that we have to deal with it honestly at every single level because when problems scale up, they don't necessarily get more predictable. They might be getting more complex, and that can introduce a whole lot more uncertainty. So that's why we're so passionate about reducing uncertainty whenever possible and promoting self-efficacy and agency. We want to be honest and transparent. We want to give people good information and encourage them to make good choices. This has implications for health policy and society, which we've talked about. So we have to temper realism with cynicism sometimes. Is it realistic to expect some people to panic? Yes. Uh, is it realistic to expect all people to panic? No. That would be cynicism. We can't predict that, in fact, and it gets complicated. But this chapter in the textbook reminds us that that's kind of a fallacy in itself to assume that people will panic if they encounter crisis. That's not really how crisis works. That's not how coping works. That's not how human brains work. And so we do have to balance realism with cynicism when we're dealing with these kinds of challenges. So we should hold our leaders and public health officials included to higher standards. We should hold our leaders to higher standards. So let's look at some lessons for public health here now specifically. These are coming from the textbook. They're a good summary of the things that we just talked about. One, have a plan. That's great. Two, cultivate ongoing relationships because one of the first steps of every one of those plans is knowing who's doing what, when, and why, and how, and all that good stuff. Cultivating ongoing relationships with the public in our communities, that is capacity building. That is making it so that when we have to respond to health issues, it doesn't go horribly wrong and we can predict things better, we can reduce uncertainty. We can build an information library, make sure that we have enough resources around that we have something to reference and public health practice and current literature. We want to have the clearest picture possible. Emphasizing teamwork. That's pretty straightforward as well. Part of that ongoing relationships. Well, part of that is that people do have roles and responsibilities and they have to work together, and that works best if you don't just have one person in charge of everything, dealing with everything all at once. No, we need specialized roles. They help with all of this. Recognizing diversity of opinions, people, backgrounds, all that stuff. Diversity is important. We also want to recognize diversity on the public side of the public health in terms of stratified risk. Not all communities suffer equal risk or have similar exposures. Not everyone's going to respond the same way. Not all the social motivations are uniform across the country, across a state, let alone a country or a municipality. So we need to recognize all that stuff. Keep communicating. That's a good one. Let's talk to each other and continue to do so. We have to keep that open communication. Remember the CERC model there, that once we've responded, we need to encourage discussion so that we can be better at it in the future. We don't just want to sweep things under the rug and then avoid responsibility. We do need to improve our system if we want to avoid horrible problems in the future. Be honest and consistent. That's really important too. Let's have some consistent messaging and stick to it. Honesty is part of that, because you may think you're simplifying things, but you're not. You're adding uncertainty into the whole thing if you are not willing to be honest. So we have to be honest and transparent. So what does this mean for you as an individual? I think that's it's a good place to transition this to as we wrap up this lecture and put a pin in this semester. So these are lessons for public health officials. You should probably be asking yourself at this point, are these realistic? We see that word come up from time to time. Are these just ideals or realistic? Well, I think the short answer is both. We should aim high. We should hold our leaders accountable and expect them to do a good job, because this is an important job. So these goals may be difficult, but I do think they're realistic, and I think they're important standards to maintain, as I mentioned at the beginning of the semester. Now, what does that mean for you at the individual level if we try to scale this stuff back down to a place where it matters for you as a person? Well, in addition to holding your leaders accountable, we should recognize that a lot of this is contingent on reducing uncertainty in individual action. If you think back to our early discussions this semester, I would like to emphasize for you again the importance of health literacy for individuals and individual action. You can improve your health literacy all the time, but we've also spent a lot of time talking about individual biases, those kinds of individual biases that get in the way of public health officials doing this kind of stuff, and the kind of biases that get in the way of you receiving messages. And remember that people focus on the negative when they're stressed out, that we get in this heightened state of arousal, and we want to take action, but sometimes we still need to be questioning kind of our biases and our reflexes and our responses to things. I'm sure you're sick of thinking about the COVID-19 pandemic by now, but we're getting to a point where, like, there's just going to be more. We live in a globalized society, and we have to think very seriously about how we want to respond to public health crises. What is a public health crisis? How should we deal with that as a country? Well, that's a big question. But for you, you can always think about how you're going to how you're going to respond. What do you think is responsible individual action? How much restriction of your freedom are you willing to tolerate, and do you think we should tolerate? Those questions are kind of secondary to the quality of our leaders, and we want to remember that as well. But hopefully this helps us think about what this might look like a little bit. So I believe this matters both for society and for you as an individual, because if we don't get it right as a society, if our public health officials don't get this right, then it kind of doesn't matter what you do, does it? Because the response is going to be really inconsistent at the very least. Well, anyway, far be it for me to end on a negative note. The goal in discussing all these things and discussing them last is to revisit recent examples of health communication that I hope are salient to you still, and maybe demystify some of that. My goal here is not to play a blame game, but to point to the established, tried and true principles of public health and health communication, and talk about the ways in which you as individuals can make use of them, and we as a society can apply them towards greater health for everybody. All right, well, that's it for this video, and that's it for this semester. I hope you guys learned something. You know where to find me if you have any questions. That's it.